Autologous transplantation remains an important treatment modality for amyloidosis, but patient selection has still always been the key. One of our current challenges is that a lot of patients with amyloidosis, well, most of the patients with amyloidosis are treated with Daratumumab, Cy-BorD as the frontline treatment. We get good responses, we get deep responses, and we think there will be long-lasting responses. So our challenge at the moment is deciding which patients are suitable. We've got criteria that have been published by the International Society of Amyloidosis, as well as different centers based on organ function and patient functional assessment. But the key is, should all patients who get a good response with Dara-CyBorD receive a transplant? Because there is a risk of mortality and morbidity with transplantation. And it may well be that we select the higher risk patients, those with more myeloma-like features, those with more high-risk cytogenetics. We also showed that patients who relapse early, within 2 years, have poor outcomes, and maybe patients who get a CR but relapse early should be considered for autologous stem cell transplantation. So I think there's a role, but its position in amyloidosis has to change now from where it was before. And we have to relearn how to use transplantation, although the very long responses that we see with autologous transplant, we have not yet reported with any chemotherapy. So the patient eligibility for transplantation has been refined over the years. The general rule is these are patients who are fit, generally patients under the age of 70, all the selected patients over the age of 70 may be considered. Good renal function with a GFR of more than 30, no significant bleeding disorders, patients with good cardiac performance status, and the numbers vary with NT-proBNP of less than 5,000 and a troponin of less than 0.06. We in UK tend to be a little bit more stringent. We like our NT-proBNP below 1,000 because we do feel that even patients with high proBNPs are at risk. And then patients with one or two organs affected rather than multi-organ amyloidosis, patients without significant autonomic neuropathy, and patients without recurrent pleural or pericardial effusions, which are all signs of high risk for complications.